So, Dr. Sandhya, after having diagnosed them as hereditary or non-hereditary, do you think hereditary cancers or hereditary colon cancers specifically, do they behave differently, or are they similar to, their trajectory is similar to sporadic cancers?
So that's a good question, Dr. Aruna. So this is something that patients do ask, like what does the testing make a difference? Okay. So the testing does not make a difference in treatment except in very early stages. In early stages of colon cancer, we do a screening panel on the operated specimen called MSI testing, very technical terms, and I beg your pardon if you cannot follow these sequences. So when we identify such sequences on the tumor, they are patients who relatively do well in early stages, and we might probably not end up even giving chemotherapy. The surgery will be the only treatment. So then what makes relevance for such testing is they might be prone for other cancers. So we need to screen them for other cancers in their lifetime, and we also need to identify whether their family members at risk. So this is where we would be much keen in advising patients on testing. So moving on with the discussion. So now that we have identified and we discussed about the testing, the relevance, my question to Dr. Aruna would be like, what are the different methods of testing? She's already answered. So when we talk about a testing, or when you talk about a vaccine for an unseen or a unacquired disease, and you're telling that you might not get in the lifetime if you give this, and we are telling that we're going to identify this gene and tell you whether you're at risk, most of the patients are unwelcome to such talks. They're like, we are safe not knowing it. So we need to counsel them. There are a lot of anxieties associated with the diagnosis, and then we will find the cause for cancer, and then we will tell whether your family members at risk, would they really want to go for it? Yes, it requires a lot of counseling. So there is something called pre-test and post-test counseling, which our molecular department actively engages in, and Dr. Aruna would touch upon that topic now.
Yes, absolutely. You're very right, Dr. Sandhya. The information has to be communicated to the patient very effectively. Just like you said, there are some patients who don't want to know the risk. They don't want to know what is in store. There are some patients who will say, I need to know. It's okay even if it is bad news, I just need to know. Either way, when we see the patient who has to be tested for hereditary cancer screening, then we do a pre-test counseling for all these patients. There is a genetic counselor who sits with the patient and who discusses the pedigree chart that I told you about. And then we kind of understand the psyche of the patient and explain to them that the reason that we do hereditary cancer screening is only to see if it is an inherited cancer. The reason we have to screen and test is to see if it is an inherited cancer. But a negative report does not mean that the patient will not get cancer. It only means that they are negative for inherited or hereditary cancers, and this needs to be effectively explained to the patient. Therefore, we do a pre-test counseling. Of course, we also tell them what we test on. So the preliminary diagnosis would have already been done on the tumor specimen that comes to the pathology department post-surgery. So what do we do here for inherited or hereditary cancer screening is we take a blood sample from the patient to see if every single cell in the body of the patient carries this alteration or this faulty mechanism that has been inherited from the parent or other members of the family. So the tumor has already been screened, already been tested. It's likely that the risk is high, and now we see whether it is not only specific to the tumor, but every single cell carries this alteration. Therefore, we call this as germline testing, and we collect a blood sample from the patient and we subject it to what we call as a test called next generation sequencing, where we take the blood sample from the patient, we extract the DNA, and the DNA is subjected to sequencing. So we all know that the human DNA is made up of 4 different bases, and we see for exact pattern of arrangement of these bases on the patient sample. in every single cell. So we come to know whether it is a faulty gene that is present in the blood sample. That means that it is very highly likely that it is an inherited cancer. Now, the percentage of cells carrying this mutation or alteration, at what frequency is it being passed on, all of this can also be determined by the next-gen sequencing. Once we have the results of the test, we do a very in-depth analysis of what that result actually means. Does it mean that we should essentially see that this particular alteration is not present in normal population. It is present in a very small fraction of population who are all likely to be carriers of this mutation. So we do a very in-depth bioinformatic analysis on the results that are obtained from the next-gen sequencing, and then we infer or deduce what is the final report. Sometimes we end up on what we call as variants of unknown significance. So we do detect a mutation. We see that there is a certain faulty alteration in the gene arrangement, but we don't know yet what that means. It may have an implication in future where we see that there are more individuals who are carrying this mutation and a certain functional analysis has to be performed. But as of now, it will remain as what we call as a variant of unknown significance. Then we call it a VUS. If we see that this is indeed a dangerous or a faulty acquisition, then we call it a deleterious or pathogenic or likely pathogenic variant, or we call it a benign. So this is the way the reporting is done, and we come to know if this patient has actually inherited this and what is the frequency of this inheritance, and all of these parameters will be reported, and then we do a post-test counseling to the patient where we sit with the patient. We remind them what we have told them in the pre-test counseling, and we go through each and every parameter and explain to the patient what it means. If it's negative, it does not mean that the patient will never get cancer in their lifetime. It only means that they will not get this hereditary colon cancer that their father, grandfather, or the immediate family member is currently having. So this is a risk estimation for the patient as well as for other family members who seek to do this testing because the patient has come positive for the same. So after having performed this test, let's understand from Dr. Sandhya what it means clinically to the patient and what will be the next course of action. Dr. Sandhya?
So yes, as we all discussed about identifying a patient for testing, then the way in the molecular department they do the testing, they counsel and they interpret the results. Now the patient comes with the test report to our clinic again, telling yes, I've been identified to have a hereditary positive gene that has caused this cancer in me. So what do I have next? So this is of relevance to us again now that we have asked for the test. So the relevance is for the patient as well as the family members. So what do we do for the patient is, like as I discussed with you earlier also, there are two different types of main hereditary syndromes that you're talking about. One is the Lynch syndrome and one is the APC syndrome. So when you talk about Lynch syndrome, we also know the set of